So thank you, everybody, because some of you came from far. You took your time and your effort to come here. So thank you very, very much for that. I'd like to introduce you a little bit, each of you, but in a way that in this introduction you can provide your insights on this subject, which I said is ensuring the sustainability, the governance, and the reliability on secondary use of health data. And we have here examples from some countries that are advancing on that governance, on that sustainability. And also we have experts that will share with us some of those big challenges that we might face. So I will start here with, over there, Janusz Picani. He's chairman at Tartu Biotechnology Park and Sakambalt. Nienke, she's head of EU Health Information System at Cienzano in Belgium. Jordi, he's representing the health strategy, the digital health strategy for the Catalan government. And Carolina de la Pinta, she's a principal PI, main investigator, Biomarkers and Therapeutic Targets at Institute Ramon y Cajal, Science Technology. But I also like your role here also somehow connected to IRyCIS. This is a large infrastructure on translational medicine in Europe. And that's, I kindly ask you, each of you, to have like a short statement, like 7 minutes, on the big challenges that you might face on this subject. So I will start with, actually with Jordi. Probably your first statement about the strategy for EHDS in Catalonia, the European Health Data Space. So everybody's going to face, this is also why we're here. We have BioCat, we are coordinators of this European Health Data Space related project, EDA. And this is also the reason why we are kind of entering in this subject with such a fierce interest, because this is something that will happen for all Europe. And the primary use of data and the secondary use of data are a reality that we will have to be ready for. And that's why I'm asking you, how ready is Catalonia at this moment? How ready is probably the other regions in Spain as well? Which is your insights on that regard, Jordi?
Yes. Thank you, Montse. And also thank you for having me, and apologies from Paul, who couldn't be here joining us today. So, I mean, here in Catalonia, you know, we have had historically a long tradition of managing health data at scale. I would say that this is one of the regions in Europe that has one of the biggest historical backgrounds in this area. I think that we have come through what I call 3 waves of digitalization of the healthcare sector. And now we are embarking ourselves in the 3rd one. But I think it's important maybe to reflect on the first 2 ones in order to give you my positioning in regards of this theme. So, you know, first, obviously, the origin of health data, it's the primary use of data, and it's clinicians and the medical records, the biggest producers of health-related information as far as for now. And this data, well, initially it was produced at the level of the service provider organizations. It was siloed in there, and that's what I call the first wave of digitalization of the healthcare sector, which was basically, let's move from the paper model into digital, and let's stay at the level of the individual organization. Then, and this happened here in Catalonia in the late 80s, early 90s, and I think that the process was completed by year 2000. Then, in year 2000, and from then on and until now, we've been moving into the second wave of digitalization, in which we have linked all these different silos, staying at the service provider organizations, and trying to achieve a comprehensive medical record or electronic health record. And we've been deploying longitudinal solutions, such as the shared electronic health record of Catalonia, such as the unique digital imaging archive, and different solutions put in place by the Catalan Health Service, by the public insurance, acting as a hub for this. And here, obviously, the governance of this has been lying at the level of the Catalan government, and well, the reliability of this data has been, I would say, mixed. The clinical information is good. The information which is related to the activity and therefore linked to the billing and the invoicing, well, there are some biases in here in this data. And it's because service provider organizations try to maximize billing when they report this data to the government. Now, I would say that we are moving into what I call the third wave of digitalization of the medical records. And in this third wave, what we have noticed is that the quality of the data that we were managing was not good enough, that with the levels of interoperability that we currently have, well, there's small, I would say, continuity of care. Obviously, there's value, but there could be way more value. And within this third wave, we think that data needs to be liquid and needs to flow all across the ecosystem. And because of that, we think that the only way to do such is following the so-called open platform paradigm. And the open platform paradigm means the usage, the systematic usage of open standards to represent clinical knowledge, having a strong governance of these clinical information models, and these information models having a strong grip on these information models, share them with all the ecosystems so everyone is using the same clinical information models. And in this way, we think that we will be able to have this data being more liquid and also fostering innovation and our ecosystem developing applications and technologies and services on top. My last comment, so when it comes to the EHDS, obviously we need to see which will be the technical requirements. You know that this is not very well defined and it's quite open. Right now, we think that we are ready. I mean, with the outcomes that we see from TEDAS, from EDA, and from other projects, My Health at EU, we think that we are ready to connect to it. If it's going to be PDFs translated into English, this is easy for us. But we think that another EHDS is possible in which more granular information ends up arriving in there. And we are getting ready for this. That's what we are doing. And my last statement in this is, and also linking to the title of the session, and when it comes to the sustainability part, I think that we need to have this, some of the times, uncomfortable conversation in the public sector, which is, can we talk about establishing some data services? Can we talk about the monetization of this data? Even though citizens need to have the control of this data, can we talk about this openly?
Well, thank you, Jordi. I think that at the end, you mentioned some relevant subject, which is the business model that will be created after that. We have people from the industry here today. Probably everybody's interested in seeing what's the outcome of these reflections, but also at the same time, seeing the difficulties. On the paper, everything is easy. So we see clearly which is going to be the structure of the governance, etc. So that's why we also have other partners here in this table that are also doing that for their own governments as well. Because on the, let's say, the design is easy, but then the implementation is really difficult. And just in one country, let's not talk about across Europe with different levels of readiness for that. And that's why Nienke probably can also share with us. You have been working on the HDS strategy for Belgium or connected to that, but also through the lessons you learned from your participation in TEDAS, this large project that also analyzes which is the readiness level for different countries related to HDS. Which are your insights here and from the conversation we had also with Jordi?
Yeah, thank you, Montse, and also thank you for the invitation. So yes, within our unit, we are running multiple projects when it comes to facilitating the use of secondary use of data. One of which is indeed TEDAS, so the Joint Action Towards the European Health Data Space, in which we aimed to provide the European Commission with some guidelines and some recommendations on the actual proposal, which was then proposed in May last year. Before we created our recommendations, we did 12 country visits, as we call them. We did mappings, a mapping of the state of play of 12 European countries with regards to their health data management system and their readiness to actually join the European health data space. And here I would like maybe to focus on 3 different topics. So infrastructure, I would like to focus on governance a little bit, and on quality, because those 3 things are very important when it comes to ensuring sustainability of secondary data use. So when it comes to infrastructure, we saw that many European countries actually have quite rich health data landscapes. Although these data management procedures are quite scattered among different stakeholders. And here, only a few countries showed some centralized systems when it comes to data management. We also saw that a lot of the countries were on their way when it comes to digitalization. So that's why I'm very happy that my colleague Jordi actually presented these 3 waves of digitalization, coming from paper pencil towards actually perfect semantic interoperability. So that is impressive. So digitalization is actually one of the key requirements of the European health data space. And finally, when it comes to infrastructure, the use of a persistent unique identifier to collect health data is actually quite important. This to ensure linkage, but also data enrichments, etc. So when you focus on governance, in our country mappings, we saw that there was a lot of differences when it comes to the legal frameworks that regulate the impact of use and reuse of health data. And actually, when you talk about barriers of the European health data space, legislation was mentioned as one of the main barriers. For example, a national interpretation of the GDPR, a quite strict interpretation of the GDPR that is captured within national legislation, can be a main barrier. Or, for example, no legislation at all when it comes to secondary data use. So the TEDAS actually has provided some recommendations for local ministries and governments for a new legislation that can complement the European health data space on a national level. For example, choosing public's interest as a main basis, choosing for security and privacy by design when it comes to health data management procedures. And of course, maybe some thoughts and policies about sharing data across European borders. And then finally, when it comes to data quality, a lot of the countries actually do still some manual checks, although we also saw some countries have some automated processes when it comes to data validation, feedback loops, etc. And here it's quite important to actually work on a fine working definition of data quality. What is data quality? Is it coherence? Is it coverage? Is it relevance, for example? And in a new project that will be starting in January, it's a project sponsored by DG RTD, it's an Horizon project, the Quantum project. We will actually create a data quality and maturity label that you can stick onto your data when you push it towards the European health data space. So Belgium actually has the presidency in the next half year, which will be quite exciting because the legislative proposal will be up for a vote in the week of April 22nd. So this is quite exciting that it happens under Belgian presidency. And Belgium is also preparing itself rapidly for the coming European health data space by setting up a new legal entity, a health data agency that will actually take care of a lot of the requests that will come in and health data management procedures as well. Maybe also an eye on the future, because the legislative proposal has a reference to a lot of implementing acts. So we're not there yet. There will be some more acts that will actually more finely define what countries have to do in order to get ready for the European health data space. And in a new project, TEDAS 2, so towards the European health data space 2, also a joint action, which will be starting in summer next year, we will be working on some fine-grained recommendations for the European Commission when it comes to sustainability and governance of the secondary use of health data in Europe.
Well, thank you, Nienke, because that's promising, because every time a member state is their presidency of the EU, is their turn for the presidency of the EU, some advancements are made in different areas, of course, according to the agenda of those countries, right? We've seen since May 2022, when the proposal for the European Health Data Space was launched during the French presidency, if I'm not wrong, many of those countries that have owned the presidency after that probably include some minor changes in the text of the different lines of this text for the regulation of the European Health Data Space, but no major changes have seen so far. These new revisions of this text. So I hope, probably, let's cross fingers, that during the Belgian presidency, we really see some of those, let's say, focuses or these visions included in the text. So let's hope for that presidency as well. And that brings me gives me the perfect opening for Janos. Because Janos Picani, you were also at the very beginning of some of the first thoughts about the European Health Data Space with the Scambalt declaration some years ago. Yeah, it was also in 2022, if I'm not wrong. You were there, and which has seen, from Scambalt, which has been your insights, the strategy of Estonia in digitalization, but also your view on where is EHDS going, how it is evolving in terms of regulation.
Yeah, thank you. Thank you for inviting me here. And we have been working on this topic together already for some years under the European project, but Scambalt being a meta-cluster around the Baltic Sea and Northern Europe, which means that we embrace a number of health and biotech clusters since 2000. We have actually keen interests in this topic. If Scambalt started from the era of biobank and genomic banks, and this was a main interest now during last 7 years, it has been digitalization in healthcare and data. And yes, 2019 already, we were actually planning a sort of survey during the German presidency to get feedback on the topic, because as you may know, in Nordic countries, there is a quite advanced system of personal ID numbers, which means that the identification of the persons have been there already for years or decades. So, and this region is quite sort of forefront of data sharing and using data for making decisions and advancements in digitalization. So we decided to go and get feedback what the different players, industry, regional governments, academia, is thinking about this idea of having the cross-border interoperable data sharing and usage in primary and more importantly in secondary data use. And we organized a survey around 30 clusters around Europe were taking, actually participating on this survey. And during the German presidency, we actually formulated the Scambalt declaration, which was actually then submitted to the German presidency, to the German Ministry of Health. And this was used as an input to the white paper that Germany was. And this was successful. There was quite a bit interest, and that's why we continued this process during the next presidencies in Scambalt, leading this and the next quite active interest was during the French presidency. It was mentioned already, and we organized a event and sometimes of secondary or second round of getting some feedback with Genopol was as a partner, was and lead. And of course, after that, we were able to get and organized ourselves with BioCat and Health Cluster Portugal and CIBR of Council of European Bioregion, and now we are actively working together on this topic under the projects which use a similar model of working with presidencies, and the next presidency will be Belgium. And we had just, when I was coming here, a call with Hans Konstad, which was actually setting up the Belgian Health Data Agency. And I had some kind of feeling of déjà vu, because what he was telling, although there was some kind of good parts from Belgium, but it was quite similar, for example, what we see in Estonia, for example. So there is a lack of actually interoperability and data, although we have digitally, but a lot of this actually information is in PDF, which you cannot use actually. And this is quite similar in Estonia, for example, although we are quite advanced in data sharing. We have PACS systems that covers all Estonia for years already. But if you go dig down and you want to use this data, or this digitalized information, this you see that there is no data actually, what you can use. And that's why I think there is quite a bit, maybe too high expectations, what we see in this European Common Health Data Space, but we have to start from something. And I usually say that this is like to find the minimal common denominator, what we can actually start from in Europe.
So, yeah, thank you, Janos. We wanted to bring this subject to you today because this is a gathering of research people from the industry, cluster or umbrella organizations, technological centers, many, many different perspectives on how data from patients and data from the healthcare systems are going to transform probably the same healthcare systems, but also the way the industry is working with that. But also the research, and that's why we also wanted to have here Carolina de la Pinta, because, I mean, let me say that we don't see patients in the panels, and that's a pity. That's true that we always talk about patients, and they are not here, but they are probably through here, through you, because you work with patients, you see patients, and I'd like to probably ask you to share with us your perspective on that, on the use of artificial intelligence, on the research, on the clinical decisions, the clinical challenges that you face, and where are the patients there? Thank you, Carolina.
Thank you, Montse. Thank you for the initiative. My profile is a little bit different for my colleagues. I am radiation oncology. I treat patients, I see patients, and I clinical research and member of IRyCIS. IRyCIS is a platform, is an initiative, a European initiative to include different countries in Europe. And the mission of IRyCIS is develop artificial intelligence. In artificial intelligence solutions include algorithm solutions and imaging processing. The algorithm solutions in our clinical practice, we use algorithm solutions, for example, in a type of breast cancer, in situ carcinoma breast cancer. We use the Van-Nuys prognosis index to classify the patients and decide the treatment. For example, in low risk of patients, we use only surgery, and the intermediate risk, we use radiotherapy and surgery or similar. Because we think the use of medical data and imaging and the processing of imaging can be very useful for the clinicians. In the part of the imaging processing, we have solutions for different aspects of the clinical. For example, when we treat with radiotherapy pancreatic cancer, sorry, we have different changes in the imaging, but don't make the results. We don't know if the patient have a good result or is in progression. But the radiomics can be make the solutions for this problem. And the application of AI in healthcare in the future, it will help obtain better medical care, create new approach to diagnosis and treat hundreds of medical problems, and measure physicians' adherence without the flower bias of the human mind.
Okay, thank you, Carolina. That's interesting because you were speaking and I was thinking, so if you had like an unmet need in your area, and I will just start a round of questions here. So what kind of solution you would ask a company, a health tech company or a medical device or something, or a digital health company to develop for you? What would make you happy at the end of the day with your practice that you don't have yet, for example? Because this is like a challenge for the industry, right?
I think in the oncology, the better solution is the personalized medicine, no? The biomarkers to predict the response depends on the treatment. For example, we make in rectal cancer radiotherapy, chemotherapy, and surgery. But some patients respond only radiotherapy, but we don't, the patient, we don't have what is this patient. And I think it's important the biomarkers to predict the response of the treatments. And I think the management of the medical data is a very important thing, because the data have are very powerful. If I know the personal problems or medical, I'm sorry, the drugs the patient is using, I can predict future disease.
I like that you mentioned the personalized medicine, because this is the subject of this session, of course. But I just want to go back to something that was launched or was published like in the final draft or the final version in 2023, beginning the year, which is the Strategic Research and Innovation Agenda for Personalized Medicine, that is connected to these large partnerships on personalized medicine. And they talk about three main areas. They call about triplets of action, which is the challenge, the objective, the results. And we in BioCat, we are quite familiar there. And I'm looking at Albert because he was working on that for some months, really. So, but the triplets of action are relating subjects related to research, some others related to the innovation system, and some others related to the implementation, the setting in the health system. And I'm going to ask Jordi about this, about the challenges in implementing this personalized medicine in the health system. We talked about data interoperability, because at the end of the day, personalized medicine is relying on this data for sure. So which is, from your perspective, the challenges that we have in Catalonia and probably similar in other regions in Europe?
Well, there's plenty of challenges when it comes to the implementation of personalized medicine. On the one hand, I would say, and possibly the most important one, is the trust on these solutions by the professionals, who are the ones who are going to be the users of these solutions. I'm not now talking concretely about innovative treatments in oncomatology, for example, that in here, I think it's very well explored and it's possibly the therapeutic area in which this is the most accepted. But when we are using, I don't know, systematically health data in order to try to produce insights that are tailored to a specific individual, I think that the trust is not yet there. And we fail, especially within the implementation process. And if you allow me, I will put you an example very, very, very fast. So here in Catalonia, we've been able to mark every single individual that visits the healthcare sector according to a continuous index that we've been able to build thanks to all the data that we have from them. And it's something that we call the adjusted multivulnerability groups. And it's a continuous index that defines which is your morbidity charge for each individual that uses the public healthcare sector. And in the times of COVID, we were able to observe that certain individuals above a certain threshold were at huge risk of hospital admission. They were at huge risk of ICU admission and also about death. So big hard endpoints for these individuals. And it was always for a certain threshold, all of them were dying. And this is a continuous index that we have for all the citizens in Catalonia. And it's available in the shared electronic health record of Catalonia. So we were thinking, well, let's tell the clinicians and let them know that upon admission at the emergency department, for someone that you are suspicious to have COVID, if he or she is above this threshold, there is this risk. But when patients were going into the clinic, they didn't have enough clinic to go directly into the ICU. So they had to follow all the pathway. And the clinicians would not see it. Also, we could also use this when we had to do a prioritization on the limited amount of vaccines that we had. So we had a limited amount of vaccines, and we decided here in Catalonia that we would start in the highest age group. But we knew that from this continuous index, there was people at earlier ages that were at higher risk. Well, we were not successful implementing this. We did not succeed. And it was, I think, personalized medicine, but we did not manage. So I think one of the challenges, among others, is trust in these solutions.
I think this is a very good example to understand where we are, and if we had like a time capsule in 10 years where we would like to be. Nienke, what do you think about that? Put something on a time capsule, please.
Well, this is actually, well, I think the example that colleague Jordi was presenting is very valid. So what we actually see that during the COVID-19 crisis, not all health systems that were out there in Europe were as resilient as others. So resilient in terms of the ability to absorb shocks. So for example, a pandemic that hits your health information system. And we saw that we assessed these new health information systems that were set up for COVID. Some of them were following the normal health data management procedures in a country. Others did not have such a system yet, so they had to set up new systems, for example, under emergency legislation, all very quick, not very resilient. And I think now with the new European Health Data Space legislation, which will be in place hopefully next year, I think a lot of the health information systems will be much more resilient to absorb the shocks, because everything starts with a very good, solid basis of health data, which can be translated into health information, which can be translated into knowledge using the health information, the digital systems that have been set up before. So if I would like to put anything in a time capsule, it would be actually the most resilient health systems to put forward as a best practice, because we can really learn from some of the countries that already have such a system in place. I would actually maybe like to take the example of the Nordics, the Nordic countries, which already have very solid systems in place at the moment.
Yeah, that was a good answer. Let's hope in 5 years we will open this time capsule and see if that's it there or it's 10. Because actually, I was in another meeting this morning in a conference about smart specialization strategies in Europe, and we concluded that sometimes the divide is not among countries, but within countries. So sometimes you have to solve the divides inside before, and not at the same time, of course, thinking about solving divides across Europe. And there, Janusz, probably you have an idea on that. The Nordics, Scanbalt is covering quite a large area. I would like also to ask you, what's next in this opt-in, opt-out that you might be facing? And please share some new ideas with us that you might have.
Well, you probably expect too much from me. I think this is one of the most complicated issues in Europe, because there's such a diversity in the approach. If you do north, south, and maybe east, west of the pattern, and there are the problem, so the devil in its details as well, because although we speak about opt-in, opt-out, but if you look to the granular way to this...
May I ask you to share what probably everybody knows, but opt-in, opt-out, and you have a good experience about that in Estonia.
Well, yeah, in Nordics and maybe in some other countries, we say that there is a question that by the local legislation, if there's a foreseen that if persons have given already consent to use the data for treatment, that it was specific purposes, there is no need to go back and ask a new consent if for the secondary data use. And for example, if we had a conference in France with Genopol, then it's obviously that there was strong position from the ethicists in France that this is not possible. Each time, if you want to use again the data for secondary use, either commercial research or public research, academic research, you have to go back to the data subject and ask again. But this is obviously makes the data, and if it's data pseudo anonymized, it's a complexity that it adds, and this makes it research very complicated. So this is one of the examples of what we face in Europe. Of course, there are other like technical and interoperability. So if you speak about what happens in next 5 years or 10 years, I think the developments will be in very small steps. But it's important to start from somewhere. And then it's obviously will evolve, and maybe it's not cover all Europe, but it's some basic principles, and then there's some groups of member states will move to more deeper and more quicker, and the others will actually follow. Perhaps if it's this forerunners will be successful. For example, we have some examples already for primary health data use, where we have already about 2 years there. Electronic prescriptions can be used across border between Estonia and Finland. And this proves to be very successful, and we see now that some other countries will follow.
Thank you. And I think we still have time, but for the sake of the whole afternoon, probably we will just speed this a little bit up. But open the floor to the questions from the audience, and you remember about pressing the, yeah, there's one over there. Remember pressing the button for, and another one here. So yeah, who's, yeah, start please. You have to press the button. Probably use another one. I don't. Okay, that's good. It's going to be recorded. We're going to lose yours, but anyway, the answer will be there.
I think it's important to remember that here the personalized medicine. And one part is to achieve this, but to get the personalized medicine, we understand a really deep understanding of each illness. And to get that, it's really important investigation, the innovation, and all the system, which all of that get it there. Right now, the European Parliament is getting a proposal of the European Health Data Space, which is focusing which works on for the citizens data that get to manage their own data, and also to get an efficient framework of the second data. So I would like to know how does this European health data space would help to achieve this aim of the personalized medicine in each of your fields.
Who's going to take that one to start? Linke?
I can maybe give it a go. So maybe it's good to remember how you end up doing personalized medicine, because for that you need solid research and you need data, and preferably you need big data. I'm going to say it because we all know it. You need large sample sizes, especially if you want to do the new machine learning algorithms that are developed. If you want to do AI, looking at my colleague here on the far left, for you on the right, if you want to do AI on large, you need large data samples. And the only way to get all the data that you need surfaced is to put into place a legal framework that allows you to find data that you need. And that is what the European Health Data Space will do for you. It will make sure that all the data that is now locked somewhere in a data holder that we don't know of, this data will surface and we can use it. And by doing so, we can hopefully give a big boost to personalized medicine.
Thank you, Ninke. Some other insights on that? Are we there, Carolina, for personalized medicine?
Well, I think it's very important apply the personalized medicine, because we use aggressive treatments and we have events adverse very important. And if we put the treatment for each patient personalized in this patient, the event adverse reduce and the exit of the treatment increase. And I think it's very, very important working in this aspect.
I think that is also now worth mentioning that IRyCIS actually just produced, it has somehow a relations with that, the multi-omic toolbox, just to help researchers to approach this translational medicine, which at the end of the day is going to fit also the personalized medicine a little bit better for researchers, but also for clinical researchers, and bringing the solutions to the practice. I see Albert also that he raised a hand.
Okay, thanks. Sorry, congratulations for the, and I think regarding to the previous question, rare diseases is a clear example of the European health data space, because we have lots of problems with clinical trials on rare diseases, because normally each country has very small amount of patients. So I think in this case specifically with rare diseases, I'm in a hospital, so we work a lot with rare diseases, and that's one of the problems we have. My question, I don't know if it's a question or a concern, it's about the GDPR and the interpretations of the GDPR each country
does. And for me now, I would say probably I would jump on the arena saying that's my first fear or challenge that we face. Because we work a lot with different hospitals in Europe. We are I'm from Vallebron, and we are in alliance with different hospitals, and we see that the interpretation that each country has on the way that you use the anonymized data and what it means to be anonymized, and how you prove that's anonymized, and all these kind of the interpretations at the ethics committee and the legal department, and it's not the same, and that's a problem that I don't know how to solve. That's my fear, that we can get stuck at legislative interpretation.
Albert, thank you. I think that Jordi will answer. We are running out of time, so a very synthetic answer.
Yeah, I will give you my take. I think that we really need to ensure that within the European health data spaces, there's a devolution on the control of the data towards patients. And if they are aware, which they are not now, but if we manage for them to be aware on the usage that we are giving into their data, I think that we will be able to gain the trust that I think it's, in some countries it's there, in some others it's not. And this will foster, this will allow us to overcome all the stupidity around GDPR.
Okay, I think that's a call to action for the industry. Very quick, because we are out of time, but yeah. No, please, very quick.
Quick question, what's the timeline for an actual unification? And is there any lesson that we can learn from healthcare information exchanges from the US?
Okay, who's taking that one? A timeline, probably not the end of 2024 as expected, and some learnings from other systems like US.
Good question. The timeline, yeah. So for the US, so we have been looking at the US systems because the US, of course, is a federal country. So the problem is, what system will you be looking at? Some are very digitalized and some have very nice collaborations. But legislative frameworks are quite different when it comes to comparing the European situation with the US. So for now, actually, we're doing currently a study about, for example, consent, comparing the consent legal structures for the US and Europe, because now it gets more important, also because of the GDPR issues. So this is still ongoing work at the moment. So sorry, I cannot answer your question. Please.
Thank you again. Like I said, a call to action for the industry. Sorry, and for the time. Thank you very much, all the panel. That was very enlightening.